Welcome to the Myeloma University module managing BCMA bispecific antibodies in the community. My name is Mary Steinbach, and I am a nurse practitioner specializing in multiple myeloma at the Huntsman Cancer Institute in Salt Lake City, Utah. I'm happy to be with you today and to discuss managing BCMA-directed bispecific antibodies in community oncology practice. In this module, we will examine the crucial role of nurses in managing BCMA-targeted therapies in community oncology settings. We'll delve into how these innovative therapies transform care for patients with relapsed and refractory multiple myeloma and the essential coordination required to ensure safe and effective initiation of therapy, patient education, symptom management, and transitions of care. So let's get started. BCMA therapies are transforming care for patients with relapsed and refractory multiple myeloma. Bispecific antibodies are off-the-shelf immunotherapies that link two targets. One arm binds to B-cell maturation antigen, or BCMA, on the myeloma cell, and the other binds to the patient's T-cell, redirecting it to attack the cancer. As of this recording, 3 BCMA bispecific antibodies are FDA approved: elranatamab, teclistamab, and linvoseltamab. BCMA-targeted bispecifics have produced impressive response rates, even in heavily pretreated disease. While many patients begin therapy at academic or large cancer centers, it's important to note that these drugs can be safely initiated and managed in community oncology settings, which have the appropriate infrastructure and trained staff. A cellular therapy center is not required. The historical tendency to refer patients to large centers often reflects the novelty of these drugs, the need for experience with step-up dosing, and the frequency of second opinions at academic sites. But with growing familiarity and established nursing protocols, community-based initiation is both feasible and appropriate when clear pathways for monitoring and escalation are in place. This shift in access allows patients to begin and continue life-prolonging therapy closer to home. Because these therapies powerfully activate the immune system, close monitoring during early dosing is essential. The first doses must be given where staff can recognize and manage cytokine release syndrome and neurotoxicity, or ICANS, using the ASTCT grading and standardized treatment algorithms. Once patients complete the step-up phase and remain stable, they can continue therapy safely in their community clinics if treatment was not initiated there in the first place. Nurses are truly at the center of this care. We educate, coordinate, monitor, and advocate, ensuring patients can safely access these advanced therapies close to home. We begin with patient education and advocacy. Nurses provide patients and caregivers with clear, understandable information about what to expect. We make sure patients know when to call and caregivers understand what to watch for, especially during the first few doses when fever, fatigue, or confusion can occur. Caregivers often notice early signs of neurotoxicity, so they're included in teaching sessions and encouraged to stay engaged throughout treatment. When a transition of care must occur, nurses are uniquely positioned to ensure continuity and optimize patient outcomes. Nurses ensure that care is cohesive across settings, from the initial doses, which may be administered at an academic or specialty center, to ongoing treatment at community centers. We facilitate smooth handoffs between teams, sharing treatment histories, response data, and follow-up plans. Many patients receive second opinions at larger centers, but prefer to receive ongoing therapy locally. Therefore, effective coordination ensures a safe and seamless transition. Refer to our module on transitions of care for additional information on navigating this process. Symptom and adverse reaction management is another core nursing responsibility. BCMA bispecifics can cause unique immune-related toxicities such as cytokine release syndrome and neurotoxicity and ICANS. CRS usually occurs early during the step-up dosing phase, and neurotoxicity, while less common than with CAR T-cell therapy, can still occur. Prompt recognition and escalation are critical. Other key areas are infection prevention and cytopenia management. Because BCMA-directed therapy reduces normal plasma cells, patients are at risk for infections and low antibody levels. Nurses ensure appropriate prophylaxis, including vaccination. Refer to our module, Managing CRS, Neurotoxicity, and Infection for Bispecific Treatment for more detail. Nurses can also take a lead in general management strategies, collaborating on individualized care plans, using technology like remote monitoring or wearable devices for vital signs, and ensuring strong communication with caregivers and local providers. We educate urgent care and emergency department teams so they can recognize and manage CRS and/or ICANS correctly if a patient presents after hours. Practical support is another major component of care. Let's consider the example of elranatamab. Elranatamab uses a step-up sub-Q dosing strategy on days 1 and 4, with the first full dose received on day 8. Following response, it is possible to transition to biweekly dosing, which reduces frequency of visits for patients and helps with side effect burden. During the step-up dosing phase, patients may need to stay near the clinic for observation. Nurses help coordinate travel, lodging, and pharmacy logistics to ensure treatment proceeds without disruption. Once patients are stable, we continue to monitor them long-term, managing prophylaxis, tracking immunizations, and assessing disease response through regular laboratory tests and imaging. The overarching goal is to bridge the gap between academic centers and community practices. This means sharing protocols, maintaining open communication, and providing ongoing education for community providers. Collaboration through shared tumor boards or case reviews builds confidence and ensures patients receive guideline-based timely care wherever they live. In summary, BCMA bispecific antibodies such as elranatamab, teclistamab, and linvoseltamab represent a major advance in the treatment of relapsed and refractory multiple myeloma. Their full potential is realized when nurses lead transitions of care and manage those therapies confidently in community settings. By prioritizing education, communication, and early recognition of side effects, nurses ensure that patients receive high-quality and continuous care throughout their myeloma journey. For more information and resources, please visit myeloma.org. Thank you so much for joining me today for this discussion.